Every anesthesia provider remembers this feeling. The moment the patient stops breathing, on purpose, because you made it happen. You gave the drugs. You watched the chest rise one last time on its own. And then, nothing. The ventilator isn't connected yet. The tube isn't in yet. The patient is apneic, paralyzed, dependent on you for every molecule of oxygen that reaches their brain. And the clock has already started. To understand why this moment is terrifying, you have to understand why it happens. Rapid sequence intubation, RSI. A patient needs a definitive airway fast. Full stomach, aspiration risk, trauma, obstruction, emergency. The strategy? Induce unconsciousness. Paralyze the airway muscles. Intubate before the patient can vomit and aspirate. So you give the induction agent, propofol, ketamine, etomidate. Consciousness leaves in seconds. Then the neuromuscular blocking agent, succinylcholine, rocuronium, and every respiratory muscle in the body relaxes. The diaphragm, the intercostals, the muscles that have been moving air in and out of this person's lungs every few seconds for their entire life. They stop. The chest is still. The patient is breathing the oxygen you pre-oxygenated them with, the oxygen sitting in the lungs, the oxygen dissolved in the blood. That reservoir is all they have, and it is draining right now. Every second you haven't secured that airway, this is the window. This is the moment. Everything you've trained for exists to get through this window safely. Before the drugs go in, you pre-oxygenate. 3 to 5 minutes of 100% oxygen through a tight mask. You are washing nitrogen out of the lungs, replacing it with pure oxygen, filling every alveolus with as much oxygen as possible. This is your safety margin. This is the reservoir, the functional residual capacity, the FRC, the volume of air remaining in the lungs after a normal breath out. In a healthy average adult, roughly 2.5 liters. After full pre-oxygenation with 100% oxygen, this reservoir gives you approximately 8 minutes of safe apnea time in a healthy adult patient. 8 sounds like plenty, until it isn't, because not all patients are healthy adults. Obese patients, the FRC drops dramatically in the supine position. Fat compresses the diaphragm. The reservoir is smaller. Safe apnea time decreases significantly. Pediatric patients, higher metabolic rate, oxygen consumed faster, smaller absolute FRC. Safe apnea time, sometimes under 2 minutes in infants. Pregnant patients, elevated oxygen consumption, reduced FRC from the gravid uterus, desaturate faster than almost any other population. Critically ill patients, already depleted oxygen reserves, baseline hypoxia, may desaturate before the blade is even in the mouth. The safe apnea window you thought you had might be half as long as you calculated. And that SpO2, that number you're watching tick reassuringly along at 99%, has a lag. The pulse oximeter measures what already happened, not what is happening now. By the time SpO2 starts falling, the actual arterial oxygen content has already been dropping for 30 to 60 seconds. The cliff is closer than the monitor is telling you. 99, 98, 97. When healthy, these numbers mean nothing. Normal variation, nothing to worry about. But when your patient is apneic, when you are holding the laryngoscope, when the blade is in the mouth and the vocal cords are not where you expected them to be, 97 feels different. 95. The pulse oximeter tone, that reassuring regular beep, begins to change pitch. Lower, slower, more hollow. 93. The OR gets quieter. Not actually quieter, but that's how it feels. Every other sound fades. The surgeon's conversation stops mattering. The music someone put on becomes inaudible. Your entire world narrows to the view through the laryngoscope. 90. The brain is beginning to receive less oxygen. Not dramatically, not catastrophically, not yet, but the neurons that need constant oxygen delivery are beginning to notice. 87. This is the number that changes things. Below 90% SpO2, tissue hypoxia begins. The oxyhemoglobin dissociation curve. You are on the steep part now. Small drops in SpO2 correspond to large drops in arterial oxygen content. 83. You need to make a decision right now. Attempt again or abandon and ventilate. The view isn't good enough. The angle is wrong. You've attempted twice. 78. You remove the laryngoscope. Mask ventilation. Bag, mask. Jaw thrust. Two-handed seal. The bag goes in, or it doesn't. The bag won't go in. You adjust the mask. Better seal. Two-handed grip. Jaw thrust maximized. Still nothing. The airway is obstructed. You try an oral airway. Better, slightly, but ventilation is still inadequate. SpO2, 74. This is the moment that every airway algorithm, every difficult airway course, every simulation, every checklist was designed for. Can't intubate, can't oxygenate. The most feared scenario in all of anesthesia. LMA, supraglottic airway. You reach for it, insert it, connect to the circuit. The bag goes in. SpO2, 71. Still dropping. LMA ventilation is partial, not enough. Video laryngoscopy. Someone hands it to you. Blade in. Better view. Tube in. Cuff up. Connect. You squeeze the bag. The chest rises. SpO2, 68. Still falling. Lag in the monitor. You watch. 67. 68. 70. It's turning. 74. The oxygen is getting in. 82. 91. 97. The tone of the pulse oximeter rises back to its normal pitch. You breathe. For the first time since you picked up that laryngoscope, you breathe. For most people, that entire sequence is invisible. The patient went to sleep, the patient woke up, everything went fine. They have no idea that for some portion of that time, their oxygen saturation was dropping toward a number that has real consequences. They have no idea that someone in that room was making decisions in seconds that determined whether they would wake up neurologically intact. They will never know. And that is, in a strange way, the whole point. The best anesthetics are invisible. The best airway management leaves no trace. The patient wakes up and thinks nothing happened. Because the person responsible for their airway knew what they were doing, had thought about it before the case, had identified the risks, had a plan A, had a plan B, had a plan C, had stood in front of a simulation mannequin and practiced exactly this until it became reflex. For most people, these moments are invisible. For anesthesia providers, they can feel like forever. Every case, every induction, every time you pick up that laryngoscope, you carry the weight of that window, that brief, terrifying, extraordinary window between the last spontaneous breath and the first mechanical one. That window is yours to manage, and you were trained for this. I'm Anesthesia Buddy. If this changed how you think about what you do, share it with someone who needs to hear it. Subscribe to Anesthesia Buddy. Stay sharp. I'll see you in the next one.